I've just got a question for you, Ron, around the use of biomarkers as a diagnostic tool and a step down from IV to oral antibiotics. What's your personal view on bringing that into hospitals, and what's the UK sepsis standpoint on that as well?
So I can't speak officially for UK Sepsis Trust from an organisational perspective because we haven't discussed this at trustee level. My personal perspective is we need to get much, much better at integrating biomarkers, integrating diagnostics into clinical systems. There's a whole raft out there, and I think broadly they can be characterised into infective versus non-infective inflammation, decision support tools, viral versus bacterial versus other types of infection decisions, pathogen identification, antimicrobial susceptibility, risk stratification. Got to get better at integrating all of them. I think these are all decision support tools, as has been said. There is not one biomarker that is going to be of help in this space, but there are lots of biomarkers that can assist. And, you know, a common paradox, I'm sure for everybody here, certainly in my world in intensive care, is you have a white cell count going one way and a CRP going another way. If the procalcitonin is X, how is it going to help you in that decision making? So I think they've got to be integrated. Using PCT as an example, has my clinical suspicion of serious infection diminished? Is this patient well, as the first questions? And then what is the PCT? And if the PCT is below a certain threshold, it can empower you to de-escalate or cease or downgrade the route of administration of an antimicrobial. I don't think they should ever be integrated in a binary fashion.
Afternoon, I'm Dan Takahashi, matron for acute deterioration improvement at Nottingham. So a question for Ron. Hello. Thank you for your talk. In relation to AMS, I think, you know, just as a bit of a personal experience, a few years ago, had an awesome holiday to India, and when I visited a pharmacy there, you know, it was quite amazing to see that I could buy pretty much any medication that my heart desired. And I just wondered, you know, we're doing a huge amount of work, obviously in the UK and in a lot of developed countries, to try and protect the antibiotics that we have available to us. But I think COVID has taught us, you know, that we live in a very small world, and actually, you know, that we really do kind of need that global kind of effort for improvement. And in your various roles, I did wonder whether perhaps are you aware of any improvement work that's happening on more of a global level for AMS? Thank you.
Yeah, I mean, great and very broad question. I mean, it is well known that the governor of Chennai a number of years ago sort of tried to implement steps to ban the sort of open market availability of antimicrobials within Chennai. That was moderately successful for a period of time. It is still talked about globally, but we've got so much more we need to do. I think we need to remember this is not just, and I alluded to this is not just about inappropriate consumption of antimicrobials by humans when it's intentional. This is also about non-intentional consumption of antimicrobials. It's about antimicrobials in our food chain. It's about the use in intensive farming. It's, you know, in the UK, for example, it is quite rightly outlawed to use antibiotics as growth promoters, but if a single animal within a herd or a flock is sick, then the farmer or the vet can treat the entire flock with antimicrobials. These, of course, are excreted into the soil, into the crops on which they graze, into our rivers. We've now got 1 in 8 rivers in the UK test positive for multi-drug resistant E. coli. In Greece, it's even worse. It's 1 in 2 rivers. We have surfers who are 4 times more likely to be admitted with resistant infections than people who don't surf. It's horrific. So we've got environmental contamination by hospitals, environmental contamination by intended use in humans, environmental contamination by inappropriate use in animals, and we've got to address all of this. So yes, this is sepsis advocacy, but it's also Compassion in World Farming, it's the Soil Association, it's all of these other agencies, and it's politically, particularly in North America, extremely sensitive when you talk about meat consumption.
So I can...
Sorry, that was a very soapbox answer, wasn't it?
Thank you. I can also
Thanks,
add to
Ron.
that because of my role as antimicrobial stewardship lead. So globally, thank you, Ron, I think all those points are really valid. So globally, there's a lot of work going on. So there's a UN General Assembly declaration. So there was the first one in 2016. There was one in 2024 where all heads of states for all countries, I think 192 countries, signed that they were going to focus on antimicrobial resistance. If you think about the different government changes we've had, AMR has remained a priority in the UK. And it is a priority in many countries. The challenge is funding. I will say that in no country across the world is it illegal for you to be able to buy antibiotics just like that. The challenge is there sufficient access to care? So we have to be careful when we're in a high-income country and we start to talk about how people access antibiotics, because in many countries, the issue is not access. We have excess issues in high-income countries. The issue is access, and they don't actually have good access to care. So no one's going to advocate for sales of antimicrobials, but I think we just need to also be cautious that if they cannot access antibiotics at all and they cannot access a GP or anyone else for their health care, then what happens to those populations? We already see there's already high levels of sepsis. So it's a very nuanced and very challenging situation. But what I can say is that there is no country where it is legal, where it's that you can just buy antibiotics. Some countries are starting to put systems in place that allow pharmacies, for example, to have some training, which then mean that they issue antibiotics. We have that in the UK, but in Ghana and a couple of other countries, they do that. In India, they do have a red line. So whilst you can buy, they did have a red line box. And there are some antibiotics, particularly broad spectrum ones, where even the medicine sellers couldn't sell them. So there are challenges, and I totally agree that we need to think about this on a global level. In terms of the UK and farming and animal health, they have reduced more antibiotic use in animal health than we have done in humans. So again, we need to think about what we are doing across humans as well. So great question. Thank you, Ron. Just needed to add that. Maybe a bit of a soapbox as well from me. Okay, any other questions? If not, I've got a question for Ron. I've got a question, which is one of my soapboxes. But so in terms of what colleagues were talking about that they learned or wanted to learn from today, were there any of you that had a learning point that actually these 2 sessions supported or gave you the learning you wanted, or actually there's still a missing something in your mind, like they should have covered that, but they haven't covered it? Okay, so Ron, I'm going to ask you a question. I'll give colleagues a few more minutes to think about if they've got any questions. So Ron, when the Sepsis Trust, so one of the key things and that has happened over time, and I think since COVID, we can no longer hide from the fact that there is health inequalities across infections. I think pre-COVID, we could say we don't have data, we're not sure, but since COVID, we know that can't happen anymore. I asked the question of Emma earlier. I'm not going to ask you the same question, although I'm tempted to. But one thing I wanted to just check in is how are factors associated with health inequalities being built into UK Sepsis Trust tools?
Yeah, I mean, that is a great question, and it's really difficult for charities. When we put out, we openly advertise for trustees, and, you know, we advertise, I hope, without prejudice, but we very rarely get people from areas of high socioeconomic deprivation applying to be trustees. We very rarely get non-Caucasian people applying to be trustees. So it can be really difficult. But what we are doing is we're working with agencies who represent underrepresented communities to try to make sure our materials are accessible. So one small example is I talked about the Health Hero Class 1 medical device. So in there will be advice for people how to detect skin color change in people with more darkly pigmented skin. We try to work, so we've worked with the various organizations such as the Ahmadiyya Muslim Youth Association. We've worked with the prison service. We work very closely with Iceland Foods, the sort of frozen food retailer who try to deliver high quality protein to people on lower incomes. Okay. We do our best, but it is really difficult. And if people represent any agency that can help us penetrate these underrepresented markets better, we have a will to do it. It's just for a small charity. It can be really challenging. No,
totally agree. Thank you. And I guess in the NICE guidance, which was updated, they do talk about some factors associated with health inequalities. And I do wonder if those are even built into the tools. And I am actually going to ask you the question I asked Emma. So Academy of Medical Royal Colleges, the statement came out, and I don't think there was any information in there about the link between inequalities and sepsis.
Yeah, and we've seen this, and within the National Child Mortality Database that I did present, there was evidence that people from non-Caucasian ancestry households were twice as likely to die with sepsis. In the report from the University of Manchester, I think people from households of Pakistani descent were 2.7 times more likely to die than people of Caucasian descent. We've seen data from Leicester, from David Jenkins, that show that if you're in an area of low socioeconomic deprivation, 40% of E. coli causing UTI are resistant to first-line antimicrobials. If you're in an area of high socioeconomic deprivation, it's 80%. So there is, this is not just noise. There is hard evidence out there that there is inequality. And as a small charity, it's our duty to work with stakeholders, work with other agencies collaboratively to make sure we address that. But, we are but 18 people. So
no, totally agree. And I guess, but you're a very powerful agency. And I guess with the Infection Management Coalition, I think it'll be great if that's built into that, just to encourage that consideration. I was going to ask you a question about the modifiable factors, and you've already highlighted some of those. Some of them are not modifiable, though, in terms of your ethnicity is not modifiable. But were there some other modifiable factors that you think we could think about, because that might help colleagues to start to think about interventions?
Yeah, but I mean, some of these are modifiable. It is about injustice. It is about inequality. It's not just about ethnicity. It's impossible to unpick socioeconomic deprivation, multi-generational living, ethnic background, poor diet, poor exercise, and so forth. I think at a very basic level, we've got to work out how the government and agencies can make high-quality protein available to people on lower incomes, but we also need to improve access to open space, improve access to exercise, and improve diet for people on lower incomes. Because only when we do that can we truly understand whether there's a true ethnic genetic difference in risk and outcome.
Yeah, no, thank you. I think we talk about ethnicity as one of those common ones, and if you think about across a range of health challenges, that's one of them. But actually, in the sepsis and health inequalities work, which you talked about in Manchester, which you kindly, UK Sepsis Trust provided a quote for, learning disability was one of those, and multiple uses of antibiotics, and I'll share some of that there later. Jocelyn, I'm going to ask you a question then. So we're going to create this surveillance program. What can colleagues in the room do at this stage? Because sometimes it's often like we're doing something in the national team over there somewhere, and then we expect something to happen. But what can the colleagues in the room start to think about and maybe potentially support the work?
That's a really good question.
Sorry.
So one of the really important things for us is to engage appropriately with stakeholders, and that includes NHS colleagues and charities like the Sepsis Trust. So we are working, at the moment we don't have an open inbox, but that's something that we would be launching as part of this, the surveillance program. I guess the thing to do is maybe have a chat with me today, and we can exchange emails. And that's a way to start the conversation. And I think we should probably explore something like having an open inbox that people can put, and having a way for getting early feedback. We are planning to work with agencies and we're already working with NHS colleagues in this clinical coding group. But if for more frontline staff, a way of engaging more frontline staff, we can look to doing something like having an open inbox or having some engagement fora to gain some insight from more of the on-the-ground staff, not just those who are sort of nationally recognised, into these coding groups. So. Yeah, I'd love to hear suggestions about that. So do catch up with me, and what would be the best way for getting feedback at this stage?
Yeah, and I'm going to look to Alan, actually, because Alan has everyone's email addresses, and you've all signed up here. So potentially one way is, if we do have something, we could ask if Alan might be willing to share with those who have come to this sepsis track. And I guess similarly, in that way, is one way to get engagement. Only if you want to provide feedback and you're passionate about it and want to tell us off, which is often the case. Okay.